Hi, good afternoon, everyone from Singapore. I'm Dr. Judith Wong, and I would like to extend a very warm welcome to everyone on behalf of the APICS 2020 organizers. This is the pediatric session on COVID-19 in children. Is it as benign as we thought? We have 4 speakers today, and they are from a variety of places around the world to bring us a comprehensive look on COVID-19 in children. So let me introduce our 4 speakers. We have Dr. Jayashree, who is Professor and Chief of the Pediatric Emergency and Intensive Care Units at the Postgraduate Institute of Medical Education and Research in Chandigarh. Among her many research interests includes infections, antimicrobial resistance and stewardship, as well as grassroots level capacity building. Being the chairperson of the Pediatric COVID-19 Committee, which oversees planning, organization and management of COVID infections in children, she will be sharing with us about COVID-19, the global scenario and the Indian perspective. We will also have Dr. Ramnarayan, or Ram for short, who is an intensivist at the Children's Acute Transport Service at Great Ormond Street and the PQ at St. Mary's Hospital in London. He has a diverse portfolio of grant-funded research involving pediatric critical care epidemiology, biomarkers and clinical trials. And recently, Dr. Ram co-led a collaboration on pediatric inflammatory multisystem syndrome temporally associated with SARS-CoV. And he will be sharing more about this in his talk. Next, we will have Dr. Jacqueline Ong, who is Senior Consultant and Head of the Division of Pediatric Critical Care at the National University Hospital in Singapore. She graduated from the University of Cambridge and completed a fellowship in SickKids Toronto. Her clinical interests include post-operative cardiac care, extracorporeal life support, and simulation teaching. She will be talking to us about the unintended consequences of COVID-19. And lastly, we'll have Dr. Jan Hau Lee, who is Senior Consultant at the Children's Intensive Care Unit at KK Women's and Children's Hospital in Singapore. He is also the chair of the Pediatric Acute and Critical Care Medicine Asian Network, which focuses on the research needs in Asia. His clinical and research interests include pediatric critical care epidemiology, nutrition, and ARDS. And Dr. Lee will be sharing with us about PICU COVID-19 guidelines and research directions. We will have ample time for Q&A at the end of the talks, so do feel free to write your questions in the Q&A chat room, and my co-moderator, Dr. Kashfi, Qadri, and I will pick them up at the end of the session. So now let us begin, and Dr. Jayashree, you can go forward with your presentation.
It says the host has disabled the screen sharing. So can it be enabled for me, please?
We will look into it. Give us a
Yeah.
moment.
Yeah, it's done.
Okay.
Is it visible now?
Yes.
Yeah, okay. Greetings from India. Thank you, Judith, for that kind introduction. And I'm very happy to be a part of this Asia Pacific Intensive Care Symposium. And as we all know that for the last 7 to 8 months, we have been talking only of COVID-19, and rightly so, a panel has been dedicated to this, especially with perspective from children. So I would be talking on the global scenario with some insight into the Indian perspective. Obviously, it would be a snapshot because I have 15 minutes for this presentation. So the scope of the talk, I would quickly go through the epidemiology in children. What has happened, the difference between the early and the late pandemic, the difference between America, Europe versus Asia, specifically the Indian scenario, and how the infection has affected the high versus the low middle income countries. So what is the burden in children? As we all know, it began first in China in Wuhan. So rightly so, most of the publications in the early part of the pandemic came from China. They shared their experiences with us. In one such review of COVID-19 among children in China, they saw 2,143 children, of whom 34.1% were lab confirmed, and about 65% were suspected cases as on February 2020. So this was the early part of the pandemic which happened in China. Of these, what they found was just 5.6% children constituted or fitted into the definition of severe acute respiratory illness or SARI. And a minuscule proportion developed acute respiratory distress syndrome. And the mortality was very, very low in children, hearteningly. Only one child had died. Subsequently, we had reports coming from the US, which included the period between February and April 2020, again, possibly the middle of the pandemic. And in one of the studies, data, 2,572 children were studied. They comprised only 1.7% of the total cases of COVID that were seen. Again, highlighting this aspect that children, COVID in children was a very small proportion and it was predominantly an adult disease. Of these, 20% required hospitalization. And again, a reassuring part was just 2% required intensive care unit and only 3 children died. Again, this data suggests, very similar to the data from China, that this disease was mild in children and very, very few required intensive care, and the mortality also was very, very low. Going on further, elaborating a little bit of data in USA. Now this particular data spans from March to July, again including the middle part of the pandemic. And here what they saw was, if you look at this graph, which is very interesting, they stratified into different ages: less than 2 years, 2 to 4 years, 5 to 17 years, and overall that is less than 18 years. So what they found, the topmost line, that children who were less than 2 years, they were the high risk group, and the number of cases per 1 million population, this was about 25, compared to adults, which was 164.5. When we look at the overall cases who were hospitalized for less than 18, it was 8 per 1 million population. Again, this particular graph and this particular data draws our attention to this fact that younger the child, though we say that COVID is mild and probably not so alarming in children, younger the child, the risk of the disease being more complicated tends to be higher. Also, they found that of the 576 children, when they stratified according to age, predominantly infants and later proportion, that is adolescents, comprised the burden of the cases. And most important was nearly 50% had some associated comorbidities, which again means that children with comorbidities again are at high risk. And in this particular cohort, which they had published, ICU admission was required by 208 children. And if you see invasive mechanical ventilation, where children required intubation, was only seen in about 6% cases. Majority of the patients were managed with BiPAP or high flow nasal cannula. So at the time of discharge, the diagnosis that was attributed was pneumonia, which was seen in 11.1%. But what is more interesting is the multisystem inflammatory syndrome in children, which Ram would subsequently be talking to in detail. This almost equal with the pneumonia as far as children was concerned. So this was the data somewhere in the middle of the pandemic. And the important point to note was that ARDS, again, just comprised of 2% of the children who required ICU admissions. So this again draws our attention to the fact that pneumonia and multisystem inflammatory syndrome in children are probably the two reasons why these children require to be in ICU. However, progressing on to ARDS is something which was less often seen in children as compared to adults. So coming to the next question, so what is the shift? Is there a perceptible shift between the early versus the late pandemic? So we are currently in the late pandemic. So is there a shift? So what we saw in the early pandemic, as you see in this particular graph, is that the number of cases in Asia, which is represented by this red line, was much higher as compared to the cases which were picked up in America, Europe, the Eastern Mediterranean region, Africa, and the international conveyance, that is the ship in which multiple cases were reported. And here Asia topped the list. And this is probably because of the cases from China and the other parts of the Asia. So in the early pandemic, it was the cases in Asia which were much higher than the cases in Europe or America. And this is exactly what came out in the publication from Korea, where they saw and they published reports included children and infants up to 6th April 2020, again covering part of the early as well as the middle of the pandemic. And we can clearly see that the number of cases or the cohorts, they ranged from 1 to 731 cases, and the age range was from 0 to 18, which included the adolescent. And the common symptoms that these children presented was fever, cough, hypoxia, and critical care requiring was very less, and mortality also was very less. So pandemic, that is where we are right now in October, end of September, October, you can see that Asia, the Southeast Asian region to which India belongs, there we can see that the number of cases per 1 million is 101 to 500. And there are many parts of Southeast Asian region where it is less than 101 cases per 1 million population, which means that the case surge has been decreasing after the peak that was seen in August and September. And this is exactly what was reported by the WHO latest statistics, which is inclusive up to 4th October 2020. This particular graph shows what is happening in the Southeast Asian region. So what is happening is that there is a gradual decline in cases and death in the past week. That is, this was 4th October. So what they are referring to is the last week of September. The Southeast Asian region, however, continues to contribute to almost a third of the new cases which have been reported globally in the past week, which is about 30%. And the current weekly case incidence is about 304 cases per 1 million, is markedly lower than what is being seen in America and Europe. And that's exactly what this particular graph is showing, that come September, that is the last week of September, the bar has come down. And this line, black line, single line is representative of the death, and there is a decrease in the death rate also. So Asia, especially the Southeast Asian region, the curve has probably turned down. So what is it when we compare it with the Americas and the Europe? So this is again the graph which I have picked up from the WHO coronavirus disease dashboard, which includes up to 4th October 2020. And here we can clearly see that the yellow bars, which represent the Americas, the yellow bars are much higher than the purple bars, much higher than the green bars, which represents Europe. So therefore, this means that in the Southeast Asian region, the number of cases have come down, number of cases per million has come down. Now, what is happening in Europe is again something which is alarming. The initial peak was followed by a lull, which happened in July and August. And now what Europe is witnessing is the second wave. So therefore, the number of new cases and the new deaths that are seen are increasing, and Europe is witnessing the second wave. Now, what is happening if you look at Asia specific in the late pandemic? The incidence in Myanmar, there are certain spots where the incidence has increased. For example, Myanmar, the incidence has risen sharply. The cumulative counts are almost doubling each week since August. Over 6,500 new cases are reported in the last week of September, which amounts to, because we always describe the number of cases per million, so it's about 120 new cases per million. And Myanmar has announced a lockdown kind of a thing, a stay-at-home orders for its biggest city, Yangon, in September last week because of this case surge. Now, in the same Asia Pacific, India and Indonesia, these are the two countries which require attention, because India is topping the list as far as cases per week. Since late August, the cases are peaking in India, and India has contributed to majority of the incident cases in this region, that is the Southeast Asian region, which is 91% cases have come from India. And globally, it has contributed almost 27, that is 1/3 of the cases. The deaths were also 10% of the global deaths. And it has been attributed to increase in the concurrent expansion of the testing activity, because there were several mild and asymptomatic cases that were picked up in India during August and September. However, the weekly incidence, like what we describe for every country, is now falling to 403 new cases per million after peaking in September. So in India, the cases seem to have turned around, and probably the curve is going to flatten. Indonesia is the second most affected region in Asia, and 60% of the cases have been reported from the island of Java, which includes the capital city of Jakarta. However, unlike India, the testing capacity is unable to meet the demand, and they have been able to test only 23% of about 1.3 million cases, suspected cases. Only 23% could be tested. So coming specifically to the Indian perspective where I belong to, so here we have most of the data which comes from the Indian Council of Medical Research. So in the early and the middle part of the pandemic, what happened to children as reported by ICMR was that children comprised 3.6% of the total cases when they were between 0 to 9 years. And when the age was relaxed to include the adolescent, then it constituted 8.1% of the total cases of COVID-19 which was seen in India. However, how many were severe, critical, and required ICU admission was something that was not available from the ICMR data. There have been some early published reports in India where again it mirrors what was seen in China, what was seen in, early in US. Majority of the patients of COVID-19 children were asymptomatic, and about 40% had very mild symptoms, meaning thereby that hardly any patients were hypoxemic, and no one actually required intensive care in this study, which was published in the early phase of the pandemic. And of course, expectedly, there was no mortality because there were no critically ill children. A very similar report was reported from another multi-center observational study in West Bengal, where they looked at 41 children, very similar. 40 were discharged, only one death occurred, and that amounted to a case fatality of 2.4%. There were 6 newborns, and only 2 children at that point had multi-system involvement. So they concluded that children had less severe manifestations as compared to adults, is what they concluded. So there is limited data on epidemiological features. In initial phase, everything was mild. There was no cause for worry for the pediatricians. But now what is happening is in India, we are seeing a surge of multi-system involvement. Need for PICU care has become much higher, and case fatality in one series was reported 2.4, and in another it was reported to be higher, almost double to 4.3, indicating that what we are getting now is requiring intensive care, and the mortality is also peaking. And that's exactly what a tertiary hospital data showed. Between May and June, the middle of the pandemic, 79% had multi-system involvement with predominant mucocutaneous involvement. 63% required intensive care. So there is a complete shift, a perceptible shift in the way the children are presenting from what we saw in the early pandemic to what we are seeing currently in the late pandemic. And that similar reports came from multiple tertiary hospitals from India. When we look at our hospital data, this is our hospital dashboard. Till September 30th, we had COVID-19, only 9% children with COVID-19 were admitted in our COVID facility compared to the adults. We have a SARI ward where we have screened about 1,000 patients for COVID illness. And what we saw is that less than 1 year, we had 73. So, and 1 to 12 years, we had 77 patients as compared to the older, where the case numbers were much higher. And we did analyze our early cohort of 31 patients. This was again in the early and middle pandemic. We found that majority were asymptomatic, and those who were symptomatic, the rest 50%, they had very mild symptoms. And I will show in the next slide that hardly anybody, very few required respiratory support, and the level of care of ICU was just 10%, 3 cases, whereas majority could be managed in isolation wards, again indicating that our cohort did not have much of critically ill patients. we had about 1 death in these 31 patients, which amounted to a case fatality of about 3%. So is there a difference between the high income countries and the low middle income countries as far as epidemiology is concerned? So this is of course an adult study. I could not get such comparative study in children. So what it has shown is that cases in India showed a much younger age distribution as compared to US, and this data is till 21st August 2020. The case fatality ratio overall in the Indian population that was studied in 2 states, Andhra Pradesh and Tamil Nadu, was about 2%. But interestingly, among individuals who are more than 75 years, the death in Indian data was 17.9% versus 58.1% deaths reported in US. But in India, what we found was that half of the cases succumbed within 6 days as compared to a median of 13 days for US. The reason which was attributed in that paper was delayed healthcare seeking by the Indian patients. So therefore, to conclude quickly about the global epidemiology and the Indian perspective, in the early pandemic, pediatricians were very relaxed specialty because the disease in children was mostly mild or asymptomatic. However, the disease burden in Southeast Asian region is decreasing as of now, but we need to be cautious and brace ourselves for a second wave like what is happening in Europe. But for pediatricians, the work has now increased because the children are increasingly getting hospitalized primarily because of the multisystem inflammatory syndrome. Infants and children with comorbidity are the high risk groups, and therefore the hospitalization rates are much higher in them. Fortunately for us, COVID pneumonia and ARDS is less common in children. And whatever Indian scenario that we have published data, it mirrors other regions in most aspects. With this, it is thank you from the team of PICU at PGI Chandigarh, India. Thank you once again for this opportunity to present my data, share my data with all of you.
Thank you, Dr. Jayashree. Next, we have Dr. Ram. You can now share your slide.
Thank you very much. Can you see my screen?
Yes.
Thank you. Thank you very much for inviting me. I'm very excited to be here amongst such eminent panelists. My job today for the next sort of 10 to 15 minutes is to talk to you a little bit about the multi-system inflammatory syndrome in children that Dr. Jayashree has just mentioned. And I will quickly go through the UK experience and then also generalize some of the messages from the papers that are coming out from other areas. I have no competing interests. So this is the UK timeline. So on the 24th of April 2020, by which time we had a lockdown for about 4 weeks in the UK, and we hadn't really seen many children with COVID-19 disease, a few, probably about 20 to 25 children admitted to intensive care units across the whole country. Everyone was quite relaxed in the sense that COVID didn't seem to be a big problem for intensive care from children's perspective. But in that week of the 20th to the 24th, we have a WhatsApp group of pediatric intensivists across the UK. And this is a message that I posted, having seen several cases of children that week. So you can see here, children presenting with abdominal symptoms, pain, distension, diarrhea, typical warm shock, but actually very little in the way of respiratory symptoms, mostly antigen negative, but some come back positive after a second or a third round of testing. One child, in fact, had a negative laparotomy for suspected appendicitis and crumped after surgery. And so this then elicited a significant response from my colleagues across the country. Everybody mentioned they were seeing 1 or 2 cases of this pediatric inflammatory kind of condition, seemed unexplained. Within about 3 days, this had then transformed into an alert from the Pediatric Intensive Care Society. You can see here rising number of cases, by which time many of the units were seeing these children 1 or 2 on a daily basis into the UK intensive care units. And within a week after that, the Royal College of Pediatrics and Child Health put together a case definition because at this point, there was a kind of new presentation without a very clear case definition. And this disease or novel disorder was titled Pediatric Inflammatory Multisystem syndrome temporally associated with SARS-CoV-2, very long name, but abbreviated as PIMS-TS. And if you just sort of go another week on into the timeline, and here we're just about 2 weeks from the first descriptions of this condition in the UK. My colleagues across the river from Evelina London Children's Hospital, Shelley Repagan and colleagues, published this paper in the Lancet, a correspondence of their first experience of 8 children who had presented with warm shock. 90% needed ventilation because of hemodynamic compromise. All children were SARS-CoV-2 antibody positive, but only one of them was SARS antigen positive, indicating that this was a past infection rather than an acute COVID infection. Very quickly after that, the CDC from the US reported and defined this condition and created a new name for that condition called multisystem inflammatory syndrome in children. That was on the 14th of May. And literally within 2 days after that, the first larger cohort description came out from the French and the Swiss group. And this is from the cardiologists group, who looked at 35 children over the last 2 months before that, who were presenting to French and Swiss ICUs, PICUs. Most of them were either PCR or antibody positive. Most of them, in fact, needed inotropic support, so 80%. The LV ejection fraction was less than 30% in a third of those patients. And in fact, 10 out of the 35 children needed ECMO for cardiovascular support. So by this stage, this was now being described more as an acute heart failure presentation as part of a multi-system inflammatory process. And as you can imagine, by this stage, reports were coming in from all parts of the world, and 3 case definitions or 3 sets of case definitions were evolved. One from the Royal College of Pediatrics, which I mentioned earlier, one from the CDC, which was from the 14th of May, and a couple of days after that, the World Health Organization published their case definition of this multisystem inflammatory syndrome. There are some differences in the case definitions, but the key features or the core features are very similar. If you look at the table here, or the box here, persistent fever is a common feature. Involvement of more than one organ system, predominantly the heart or cardiovascular system, was a prominent feature. What was also very prominent was significant inflammatory response. So lab markers of inflammation in the form of CRP, ESR, D-dimers, ferritin, all significantly elevated in these patients. There was some form of link to SARS-CoV infection, either microbiologically, so either antigen positive or antibody positive, or epidemiologically, a link to a contact. But very importantly, none of these children had presented with typical COVID symptoms, with respiratory symptoms, or even any other symptoms suggestive of SARS infection at all. So these are children presenting with an inflammatory picture with nothing to suggest that they had had COVID before. And obviously, as a new syndrome, other pathologies needed to be excluded. And I think these case definitions were an attempt to try and pull together some clarity for clinicians who were facing these children with various features. And as you heard from Dr. Jayashree, mucocutaneous involvement or rash and mucous membrane involvement was also another feature. And so I suppose a little bit like the 6 blind men and the elephant, we were all as clinicians terming these conditions or these children with conditions that we already knew before. So some called this just an atypical Kawasaki response or a Kawasaki disease type response. Some called it a macrophage activation. So if you were a rheumatologist, you probably thought this was more a macrophage activation type response. If you were a sepsis expert, this seemed more to you like a toxic shock syndrome or simple viral sepsis. And in fact, there was significant controversy at this time whether this was a new disorder at all, or whether we were just seeing an atypical form of other commonly known disorders. So this paper from the ID, PICU, and cardiology group from London, we put together a case series of 58 children and published in the JAMA, led by Mike Levine from Imperial College, looked at 58 children with this syndrome and tried to characterize them in comparison to the other diseases that we thought they might be. So Kawasaki disease, Kawasaki shock syndrome, or toxic shock syndrome. This paper was published on the 8th of June. So you can see the timeline is about 6 weeks from the first descriptions or the cases that we saw in the UK. Here you can see by looking at a very large Kawasaki database based in San Diego under Jane Burns, this cohort of PIMS-TS, 58 patients were compared to Kawasaki disease, small number of Kawasaki disease shock patients, and 37 toxic shock syndrome patients from the Euclids and Perform consortia studies. You can see here that the age distribution is significantly different. So much older patients in the PIMS-TS population compared to typical Kawasaki or typical toxic shock patients. Inflammatory response was significantly higher. So you can see here that the CRP response is significantly higher compared to classic Kawasaki, probably not that dissimilar from the toxic shock cohort. In terms of ferritin response, obviously the numbers are now much smaller because not many children had these measured in the past. You can see that there is an inkling that the hyperferritinemia is significant in these PIMS-TS patients. High troponin, so attesting to the degree of cardiac involvement, you can see significant elevation in troponin. Some children had troponin in the sort of thousands. Here you can see the procoagulant state that these children in measured by the D-dimers, again, significantly higher in the PIMS-TS cohort compared to Kawasaki disease and Kawasaki shock. So all these features started to tell a story that this condition was not as similar to Kawasaki or other previous conditions that we had seen. Our group in the UK, the PICU group, got together and we put together our case series of 78 patients admitted to intensive care units in the UK. And we compared them to previous historical admissions of the same conditions that they looked similar to. So we looked at number of Kawasaki disease patients, toxic shock patients, macrophage activation and HLH patients in the past 5 years. And as you can see here, this green line here represents the cumulative number of PIMS-TS patients across these weeks, starting from the first week of April through to the second week of May. Whereas the blue line indicates what you would expect from admissions of children with Kawasaki, toxic shock, and other inflammatory conditions from historical data. So significantly higher numbers of admission of children. And you can see here that the peak admission was in week April 27th to May the 3rd. And the week that we saw the first signs of these was this week when we raised the alert about this novel condition. The Surviving Sepsis campaign have published some a perspective comparing MIS-C or PIMS-TS, the inflammatory condition, compared to sepsis, because one of the key problems is that children presenting with a high fever and inflammatory markers are quite likely, before we knew anything about PIMS-TS, we would call them sepsis. And we may not have had any microbiological confirmation or even any identification of the organism, but we would call them sepsis. So looking at this table that they published, respiratory symptoms are much less common with PIMS-TS. GI symptoms are much more common than sepsis, and rash and conjunctival redness are much more common in PIMS-TS compared to sepsis. So I suppose some clues as to how we might be able to distinguish septic patients from PIMS-TS patients. There are also some lab markers that the Surviving Sepsis campaign indicated. So severe lymphopenia is quite common in PIMS-TS, not so common in sepsis. Thrombocytopenia is uncommon in PIMS-TS, whereas we know from sepsis presentations that thrombocytopenia is relatively common. Hyperferritinemia, particularly severe hyperferritinemia, is much more common, as you can see here. So this study from in August now from the CDC was a very important and seminal paper, because this compared 520 children with MIS-C or PIMS-TS, whatever you call it, the inflammatory condition, and using some statistical techniques called latent class analysis, automatically classified the children into 3 groups. So a class 1, a class 2, and a class 3. And what was obvious was that class 1 was more the classic, the pure form of the inflammatory condition. Class 2 was more acute COVID infection, so more the type of patients that Dr. Jayashree was talking about with respiratory involvement in ARDS. And class 3 was more like Kawasaki disease, the stuff that we knew before. And you can see here there are significant differences. For example, if you look at the pure classic MIS-C class 1, They are older than the Kawasaki patients. They have very little antigen positivity, whereas with acute COVID, 84% were antigen positive, so they were acutely infected. Abdominal pain seems to be a significant feature of this class MIS-C classification. Shock, very common, 3/4 of patients had shock. ARDS, only 7%, but 10% in the acute COVID classification. More relevantly for us in the PQ world, ICU admission rates were significantly different. About 65% of these patients in the classic form were admitted to ICU. You can see here that several, a third plus, were in shock, and some, as you can see here, had coronary artery dilatation or aneurysm similar to Kawasaki disease. So this was not a mild infection like we had seen before. This was a significant response, inflammatory response needing ICU admission, cardiovascular support, and possibly some cases needing ECMO. Probably the best summary of everything I've said so far is contained in this systematic review. So this was published in Lancet eClinical Medicine just a few weeks ago. And the key things I wanted to just quickly highlight is that 39 studies were included in this systematic review with 662 patients. So clearly a big systematic review putting together all the findings from previous studies. The patient age was 9 on average. They were mostly either antigen or antibody positive. Only 15% didn't have antibody or antigen positive, and they were epidemiologically linked to SARS-CoV by contact in the family. 70% needed admission to ICU, and you can see here that abdominal features, gastro features, abdominal pain and diarrhea were a really prominent feature of PIMS-DS or MIS-C. Dyspnea and shortness of breath, not so common. Rash and edema to the extremities, much more common. So in this systematic review, we also know that inflammatory markers, as you can see here, are significantly elevated. So to give you an extent of the numbers, the average CRP in these patients is 160. The average ferritin is nearly 1,000. And the average interleukin-6 levels is 184. So very, very significantly elevated inflammatory markers and a procoagulant state, as you can see here as well from the D-dimers and the fibrinogen. What happened to these patients? The systematic review gives us really good information on this. So you can see here 70% admitted to ICU, 60% with shock, 50% needed vasoactive support, and you can see 4% needed ECMO and 1.7%, so nearly 2% of these children died. And I think you saw Dr. Jayashree's slides earlier mentioning some variation in the mortality rate for PIMS-DS. From the systematic review, it's around 2%, but there has been center-wide or even report-wide variation in the outcomes. You can see here also that aneurysms of the coronary arteries or coronary artery dilatation or prominence is actually in 15% of patients. What about treatments? Most of them received immunoglobulin because these diseases were considered to be similar to Kawasaki disease. And I can show you very quickly in the next few slides how the national sort of guidance in the UK evolved for it. What about the pathogenesis? I don't think we understand this very clearly at all. And in fact, a summary of this entire slide can be summarized in this last paper here, which is we still don't know if it's a post-infectious syndrome or is it a persistent, cryptic, latent infection that we just can't get any antigen positivity from. So it is possible that some children have immune defects that allow them to harbor the COVID infection as a latent sort of very mild infection, which is undetected, and that drives the inflammatory response. And there's more evidence emerging of that, supporting that from gut studies, looking at microbiome changes within the gut. But the more accepted explanation is that this is a post-infectious syndrome. So this is an antibody-mediated enhancement response. And there's also been some studies looking at the spike protein in SARS-CoV, which elicits a superantigen-like response, like in toxic shock syndrome, which is why immunoglobulin and steroids seem to work quite well in this condition. So treatments. In our cohort of ICU patients, what we found was that in the first week where there were cases, not that many patients got immunoglobulin. So immunoglobulin is this kind of red line here. 30% had immunoglobulin, and only about 50% had steroids. But by the end of the next 3 to 4 weeks in the UK, somehow we had all coalesced into one sort of orthodoxy here. As you can see, most of us were giving immunoglobulin, steroids, and antiplatelet agents. And in fact, 30% of patients were getting biologic therapies like tocilizumab and infliximab because of severe inflammatory status. And that was reflected in guidelines across the world, as you can sort of see from the American College of Rheumatology and other guidelines. We did a Delphi exercise in the UK to put together a consensus management pathway for PIMS-TS. And I think the key point to make here is that we encouraged everybody to enroll patients in the UK into the recovery trial. The recovery trial, although it's an adult trial, have created a platform for pediatric patients with PIMS-TS. And the randomization currently in recovery says no additional treatment, so standard of care without any extra treatments, azithromycin, corticosteroids, or immunoglobulin. And these two latter, corticosteroids and IVIG, are only relevant for PIMS-TS patients. So we encouraged people, because there's absence of evidence of benefit, that people could be randomized into these arms to gain more evidence. But in the absence of being in the trial, we recommended that the first line treatment would be IVIG, 2 grams per kilogram. And for children who are under 12 months or already have coronary artery aneurysms, that there would be an additional drug, i.e. the IV methylprednisolone, added at that stage. But if you didn't have that, you would have IV methylprednisolone as a second line, and then biologic therapies such as tocilizumab and infliximab as a third line therapy. And that was the national guidance that we've evolved. So to very quickly summarize, sort of a lot of knowledge in the last 3 months has been gained on this condition. It started really in April, but by this stage we have case definitions from PIMS-TS, MIS-C, and from WHO. It's similar to Kawasaki disease, toxic shock syndrome, and sepsis, but from evidence we've gathered so far, there seem to be differences. And so it seems to be distinct rather than exactly the same as the others. It's got mixtures of the others. The characteristics really are intense inflammation, older patients in our cohort, so not the babies and the infants, very prominent GI symptoms, microbiological or epidemiological link to SARS-CoV infection, very high rate of PICU admission, 70%, need for warm shock management with noradrenaline and with cardiac dysfunction needing milrinone support. Immunopathogenesis is still being worked out, and the treatment guidance is evolving, but mainly the center stones are IVIG, IV steroids, and biologic therapies. So thank you very much for allowing me to share my thoughts and my experience and a collective experience from across the world on this panel. Thank you very much.
Thank you, Dr. Ram. Just a word to the attendees. If anyone has questions, please use the Q&A function to ask your questions, and we will get to them at the end of the session. So may I now invite Dr. Jacqueline to share your slide.
Hi, good afternoon, everybody. So I hope you can see my slides. I've been given the opportunity to speak a little bit about what we didn't expect from all of this in the last 10 months, and just speak briefly to a number of issues or thoughts that we've come across as we go along the way. So having lived with COVID for the last 10 months now, I guess we've all internationally as a community gained insights into the condition, and as Dr. Jayashree and Dr. Ram have shared so eloquently about the state of affairs now and with COVID, but there's some things that I think we didn't expect as we went along the way. The first really is, I divided this really into the good, the bad, and I guess the ugly side of what we don't know or didn't know to begin with. The first thing, I guess, the good is that I don't know about certainly in your centers and where you are working in the world and centers here in elsewhere outside of Asia, but we've seen a marked drop in respiratory viruses since the start of COVID. This data that this slide that I'm showing here is actually from our local data in Singapore from Tan Tock Seng Hospital. as you can see on the slide, if I can bring up a cursor, this is my arrow. So this is, in Singapore, we labeled our stages of lockdown with this term about DORSCON orange, and this was at week 14. Up to that point, you will see that influenza rates had been over the 2017, 18, and 19 have been fairly stable, but somehow in 2020, the weekly influenza rate, as you can see, dropped from an average of about 57.3% to just 3.5% in respiratory samples. So influenza up to that point had been a prominent feature in the number of PICU admissions in both the National University Hospital as well as at KK Women and Children's Hospital, and then they just disappeared. The same can be said for RSV. This is data that has just been published recently last month from our Australian colleagues who've just come through winter, and they found a 98 and 99.4% reduction in RSV and influenza detection in Western Australian children. You will see on the screen that usually there's a peak with this dark black line for RSV and for influenza, and then once borders closed in Western Australia, suddenly the pickup rate has completely disappeared. Now, this is again reflected in Latin America. This is work done by the LARED network of South American colleagues, which also went through winter, and they were expecting a large number of respiratory admissions, and somehow that's dropped off significantly. These are from two preceding years in 2018 and 2019, and in 2020, this has largely disappeared as well. So this is certainly a worldwide phenomenon from the data that we have been seeing so far. And as a corollary to that, not only have respiratory admissions decreased, but work done in northern Italy also showed that there were a reduction in unplanned and medical admissions overall to PICU units in Italy as well, which were one of the earliest hit places with COVID. Interestingly, their intra-hospital plan and surgical admissions did not change, but they too had a marked reduction in respiratory failure. So we are not seeing this group of kids, at least from other reasons outside of COVID, and certainly with PIMS-TS. And so perhaps that is the good aspect of this, knowing that influenza and RSV can make a lot of the kids that we could look after very sick. So then if that was the good, then certainly what is the bad? And I'm going to say that this too is also bad because as we have said in a number of forums on social media and in groups of PICU consultants and colleagues, is that if this trend continues, then of course the lower numbers in PICU will have impact on PICU research, into recruitment, into studies outside of concerns about PIMS-TS. And early on in the pandemic, I think there were concerns also about what implications this may have on clinical training for fellows and trainees for this year, with potentially a large number of electives being canceled, numbers being small. Will this impact the kind of training that we can offer in our PICU? So I think this is something that I guess it's early days in terms of assessing in terms of data. I haven't been able to find anything per se, but I think this is a real concern at time in different parts of the world. Now, the other thing that is the bad is what impact COVID has had on other chronic diseases. In particular, this is data that comes from Dr. Jayashree's unit. This was looking at children presenting with type 1 diabetes to Chandigarh. And they found that as compared to preceding years, there was a marked reduction in admissions for DKA, but of those that were admitted, they were more sick. Of course, reasons for that may just be reduced access to healthcare, fear of coming to the hospital because of COVID, as well as the symptoms of DKA often being quite non-specific and patients presenting late and potentially sicker. So this is something that little, I guess, is known as yet, but also a phenomenon that I think is probably replicated in many parts of the world. And this certainly will impact other chronic diseases with reduction in access to healthcare, or people being fearful to present to the hospital in time. The other thing that's the bad is there's some early data. This is from the CDC in the US, which published this in May 2020. And they recognized that there was a gradual decline in child vaccination coverage. While telehealth has taken over many of the outpatient visits for pediatrics, I think that vaccination requires an in-person visit. In Singapore, vaccination was still considered an essential service. So I don't actually know our local data, but it is of concern that if children are not getting vaccinated, then we may see a resurgence of vaccine preventable diseases in the months to come. This is already on a context where we know globally vaccination uptake is falling in various places. And now with the onset of COVID, and if less children are getting vaccinated, then certainly this is of concern. This is just from Michigan, but it'd be interesting to know if other places are also witnessing a reduction in vaccine coverage as a result of what's been happening for the last 10 months. Now, of course, then, if there was the good and then there's the bad, and then perhaps there's the ugly. And I think what has already been mentioned in several places of great concern is the mental health of our children and families that we look after during this time. Now, we do know that with social distancing, stay-at-home orders or quarantine orders, school closures in multiple places around the world, and economic disruption, there's significant stress on children and families. And with families being confined in a small space, worry about a variety of issues, including economic stress, then this could result in increased non-accidental injury for these kids, deliberate self-harm, suicide. I have to admit, we have seen a slight, just anecdotally, a small uptick in teenagers who have, because of worries about school, exams, future, we've had a small uptick of suicidal intent and intoxication with medications necessitating them having to come to the ICU. There will be increased mental health issues, neglect, and of course the kids adolescents or children who already are vulnerable because they already have some mental health issues, then have reduced access to services. And it was of great concern during our circuit breaker in Singapore that counseling and access to counseling services during our circuit breaker was not deemed essential services. And this created a great degree of stress, I think, for families who had special needs children who had to cope with schooling them at home. And this continues in many places in the world, and is likely to have a knock-on effect that we may not immediately see outside of what we expect in the ICU, but we may certainly see these kids coming in from other stressors as a result of injury. There was also a comment, so this was a helpful table in terms of seeing what can increase the stress on children and families. And of concern is obviously the overwhelming impact that these issues can have on children. And these may end up in our ICU as a result. Small point, also there was a note about in the US, at least this was some data from the US, that there was an increase in poisonings as well, highest in children under 5. And these kids were stuck at home, perhaps, families having to juggle jobs and schooling, and there was increased exposure to children to cleaning supplies, a lot of the time they were being stocked up at home. And the poisons that tended to be called through to the call center were bleaching or cleaning agents. So I think that's something that may end up in our ICU that we didn't expect perhaps at the beginning of all of this. Now, to also then finally, I think the one thing that we are as a group also increasingly mindful of is the fact that, and I think it's been alluded to in another session as well, in terms of how we've coped as healthcare providers for, mental health care support. I think in conjunction with the fact that we have similar family stresses depending on the situation where you are, then of course, coping with a large number of patients, concerns about PPE, concerns about personal welfare and safety, coping with the lack of space, especially among the adult population, having the adult intensive care has been very tiring. And so I think all of us recognize that there is a great need for support for individuals working in these situations as well. There's been a huge number of publications. This is just a small selection in terms of supporting clinicians, healthcare providers, and recognizing that having a prolonged, I think many of us have some experience in planning for mass casualty, for a disaster response. The last World Congress in Singapore, there was a session on planning for disasters. But I think it's hard to anticipate. Those disasters are usually a one-off event and don't last up to this point 10 months. And then we're still in many places in the thick of it. So I think we need to look out for each other and recognize that there's a great deal of mental stress and exhaustion as we carry on with the looking after of these patients. So that's my last slide. I'm happy to take any questions at the end. Certainly things I didn't really anticipate at the start of all of this, but with hindsight, I think it's important to take note of. Thank you very much.
Thank you, Dr. Jacqueline. May I now invite Dr. Jan Hau to share your slides?
Can you see my slides?
Yes.
Okay. Yeah, good afternoon, everyone. I'm Jan Hau from KK Children's and Women's and Children's Hospital and ICU. And I'd like to thank the organizing committee, for giving me this opportunity to share a bit on this pediatric COVID session. So in the next 10 minutes, so that we have some time for discussion and Q&A, I would really like to just discuss briefly on the current guidelines that are available for pediatric intensivists, and whether these guidelines, how fluid they are. We'll just go through what is available currently. Okay, I have no conflict of interest, but I have a fairly large disclaimer. And, I think fortunately for us in Singapore, pediatric COVID remains a mild disease. And I think, at the national level, we have not seen a COVID in the pediatric ICU. So hopefully I won't be the blind leading the blind, but I'll briefly go through what's available in the literature, and perhaps then we can have some discussion among the panelists as well as the attendees today. So let's start off with one of the first few review articles that is available for COVID-19 in children, and this was actually written up by Jackie together with some of our colleagues in Canada, Italy, and Korea. And this review article came out in online during the early period of the COVID pandemic. And really, this was a very early work, and it was, as highlighted here, conducted very quickly within the first 3 months of the pandemic. And I think some of the main issues that was highlighted in this review article really was, a discussion on the use of high flow nasal cannula with non-invasive ventilation. They discussed a bit on the intubation process and what should we provide for the caregivers and parents given the high infectious risk. And I think what this review article really touched upon, and in hindsight, what was important was really a discussion on the surge capacity. And now looking back, we do know that certain pediatric ICUs will open up to admit adult patients, especially in Europe as well as in North America. But during this early period, and you have heard some of the panelists have alluded to, there was really no discussion at that time about shock state. Given the preliminary experience in COVID, that was really focused on respiratory conditions, and of course at that time, the multi-inflammatory syndrome was not heard of at that time, and also the high likelihood of thrombosis was also not known at that time. So this just highlights how things were changing at that particular time, and given that this review was done very early on, there were some things that were still unknown to us at that time. So I was involved together with a few other intensivists throughout the world in coming up with so-called the COVID PQ guidelines that will be applicable in both high and limited resource settings. And this was published in Pediatric Research sometime in the middle of the pandemic. As we were working on this, we divided up the guidelines into certain key elements, and would like to encourage everyone to take a look at this. And really, during that writing process, and during the revision, of course, at that time, mixed C was just coming up to attention, and actually one of the reviewers asked for how come we did not include that. And really, when we did the search for the available evidence at that time, mixed C was not even described at that time. So of course, during the revision period, we included some statements on the mixed C, and so that was included in these particular guidelines. And I just want to highlight one of the most recent recommendations or guidelines that are available for us in the PICU setting, and this comes from the European Scientific Committee, and this was just recently published, I think 1 or 2 weeks online in Pediatric Critical Care Medicine. And this is probably the most recent guidelines that I'm aware of for us here in the PQ. And what they did really was taking evidence or data from inception to really middle of this year in July 10, 2020. Yeah. So I'll just like to highlight 3 points for discussion that are discussed throughout these 3 major guidelines, and maybe later on during the Q&A we can have some discussion or maybe even topics that I've not covered. So I think one of the main controversies involved with regards to the respiratory support that we'll be giving to our patients with COVID-19. And if I draw attention to Jackie's first review article in this pediatric COVID, really their recommendation was really to suggest avoiding NIV and high flow nasal cannula in open wards. Really at that time, the concern was the risk of nosocomial infection. And there was some discussion on whether you should intubate early, especially if we do not have the capacity to isolate them well. For the guidelines that I was involved in, because we have to take consideration with regards to low resource country where advanced airway and mechanical ventilation may not be so readily available, our group decided that we will provide or we will advocate for a strong recommendation to use high flow nasal cannula as well as non-invasive ventilation in patients with COVID-19. And this controversy is not really limited just to pediatric settings. The adults, this recommendation comes from the surviving sepsis guidelines that is pertaining to COVID-19 patients. And really, they have some fairly similar recommendations. Just to draw your attention to, this guideline actually suggests that high flow nasal cannula is preferred over BiPAP or NIV. Of course, this generated a lot of discussion in the medical literature, and there were many letters, discussing the pros and cons of such an approach in an important guidelines. So I think, what I'm trying to highlight here is, as our knowledge change, throughout this pandemic, really the recommendations may change depending on our experience. Next, I'll just touch on a bit on the incubation process. Again, looking at the 3 guidelines that are available, how this has changed, in a short span of 6 months. In the first review article, really the attention was really to prevent nosocomial infection to the healthcare workers. We advocate to plan early and to make sure that all the staff are well protected with the personal protection equipment. The European guidelines, went on to suggest that we should consider cuff endotracheal tubes to minimize, alveolization, and they put in, the protection of the healthcare workers as well. The guidelines that I was involved in, although it's a weak recommendation, we, as a group, we thought that it may be a good idea if certain sites have video laryngoscopy, perhaps they should do that so that it increases the distance between the provider and the patient in these circumstances. But of course, this is just based on just very weak data and theoretical advantage. So I think we have heard quite a fair bit on MIS, and I think as Ram has alluded to, the name kept changing over the first couple of months when this was described. I think the latest is the World Health Organization has decided that let's just stick to MIS. So this is taken from the European guidelines, and I think this summarizes quite nicely the 2 major phenotypes that we will be seeing in our patients with COVID-19. One with respiratory diseases, and the other one really the MIS. And if you would like, there's 3 subgroups that the patients with MIS may present to us. One with heart failure, one with vasoplegia, and one really just involving the coronaries with not too much hemodynamic instability. And then, of course, in these guidelines, they provided some specific management and guidance. As Ram has alluded to as well, because MIS seems to be affecting many organ systems, depending on which specialty you are in, you can find really different guidelines that's advising or defining this condition. And I just pull this out to show that even our rheumatology colleagues have really started already has provided some guidance on the definition of this MIS. So I think one of the challenges for us, in the PICS ICU as well as just general pediatrician, how do we keep up with that huge amount of data or literature that's coming along, and sometimes it can be quite overwhelming. And I just want to show perhaps a good example where something that we should consider as ICU in the ICU community, and this comes from the WHO guidelines on the medical management of COVID-19. And I think the key word here is a living guidelines, meaning that this will continue to evolve over time. And this was just I think published about a month ago. And really, it is an ongoing systematic review and combination of data from large studies. And so what they did here really was to analyze, the effect of corticosteroids on COVID-19 patients. And we now know that, it is good for severe and critical patients, but those with mild disease, steroids will be harmful. And really, it is quite remarkable that, the manuscript or these guidelines, was submitted on August 28 and it was accepted by August 31st. So the turnaround time is, only 3 days. So, I think as a medical community, we probably have to think of ways how to expedite some of this information to our colleagues around the world. Unfortunately, children usually are not well represented in large trials. And so as a community, perhaps we can, consider, how to interpret some of these, adult guidelines in our daily patient care. And I think a good question is, if unfortunately you have a teenager with COVID-19, will you be giving steroids to that particular teenager? So just back to my, question at the start of the talk, so are pediatric COVID-19 guidelines moving targets? I think hopefully I've convinced you that it's a yes. But I think what's more important is we probably have to rethink our approach on how to provide timely guidelines as well as guidelines that are fairly up to date. And here I would like to just, like to introduce people to, it's quite a nice website, a nice team. I have no conflict of interest with them. They a group from the UK and Australia has actually done quite remarkable work on keeping up to date on the literature on COVID-19, and so it's quite a valuable secondary source or secondary literature that we can go there to find the most recent summary on COVID-19. So with that, I'd like to thank everyone for your attention, and I also want to take this opportunity to invite everyone to the World Congress in PICS ICU that's happening in less than 6 weeks' time. So with that, thank you everyone for your attention.
Thank you, Jenna. Okay, the floor is open to questions. If anyone has any questions, please use the Q&A function. So there's one question on the Q&A chat at the moment, and I'll read it first. Do you give thromboprophylaxis in MISC patients? Is there any score like the ISTH for children to guide the use of thromboprophylaxis? Any speaker want to take this question?
I'm happy to have a quick sort of response to that from Ms. C point of view. I think the difficulty is there isn't any clear evidence one way or the other, but we know that from practice, majority of patients admitted to ICU with Ms. C are being given prophylactic enoxaparin or other forms of low molecular weight heparin. And the evidence also is that if you have an established coronary artery aneurysm or some other form of thrombus, then you escalate very quickly to therapeutic doses of anticoagulation. Aspirin therapy, so antiplatelet therapy, is also being used obviously on a frequent basis because of the overlap with Kawasaki disease. And most patients probably will be on low dose aspirin as well. As to trials, we don't really have any trials or any evidence to support it one way or the other. But the 2 or 3 deaths that we know of in the UK have been either directly or indirectly related to severe thrombotic events. And so therefore, I think it makes quite logical sense to start some anticoagulation.
Thank you, Dr. Ram. Any other comments about this or any other questions to bring up, attendees? Okay, if not, can I just ask a question for myself? When you screen patients who come into the PICU, do you routinely screen for antigen PCR as well as the antibodies? Given that the MISC group of patients tend to be suspectedly post-infectious.
Sorry, Dr. Jayashree, go.
No, go ahead, Ram. Go ahead, please. After you, go ahead.
Just a quick note to say, yes, I think the short answer is yes, most patients are being screened because they almost always have some, well, by definition, have some suspected infection, and we can't rule out SARS infection. And the green pathway patients, who are patients coming in planned surgery, patients already have been screened pre-op to establish that they are SARS negative. So I suppose the short answer is pretty much everybody coming to the ICU is now being screened for antibody tests, antigen tests. And I think if it's a Miss-C patient, then they also have an antibody test.
We have one question here. Do you have any experience using remdesivir in children with COVID-19?
No, in Singapore, we have no experience.
Yeah, in Singapore, we don't have any experience using remdesivir in children.
We have used in about 2 or 3 children who had marked elevation of inflammatory markers and COVID pneumonia, we have used remdesivir in those patients. So that would be about 3 or 4 of them in the cohort of about 60 or 70 that we have seen till now. Not very frequent.
Yeah, I think similarly in the UK, I think a few patients, probably a handful, have had remdesivir.
I presume there's a preference to use it early in the disease course.
So it's better to be used between day 4 and day 7. And especially if you're using steroids, it's better to use steroids along with antivirals. Though if we look at evidence, we may not have very robust evidence in favor of remdesivir in children, but that's what is being done in adult. And some of these repurposed therapies that we use in COVID-19 in children are by and large extrapolated from adults. So we do use between day 4 and day 7, but with steroids and antiviral, that is remdesivir.
I wonder if the panel has any experience using other drugs, perhaps the biologics or other forms of antivirals or immunotherapies.
We had to use the IL-6 inhibitor, that is tocilizumab, in one child who had marked features of cytokine storm. The child was started on steroids and remdesivir, but despite that had marked elevation of all inflammatory markers. So we had to use tocilizumab in that child. And the child responded. I don't know whether the response was just, what should I say, self-limiting kind of a thing, or whether it responded to the drugs. It's very difficult to say because it was just one case.
Yeah, I mean, I think from our UK cohort of MIS-C patients, about 10% had one biologic or the other. So most commonly anakinra, tocilizumab, infliximab. And I think it depends on the specialty that advises you on the biologic, the choice. So anakinra was mostly advised by rheumatologists, tocilizumab mainly by ID and immunologists. So it kind of depends a little bit on the specialty who's advising you, not so much on evidence, which we don't have much of at the moment.
Yeah, absolutely agree.
Yeah, first I can pick up the point about the PCR testing and as well as the antibody testing. I think what is quite established is for mixed, the MIS. Some patients may be PCR negative and antibody positive. Yeah, so it still remains unclear. Maybe it's a post-inflammatory thing, but some of the patients that were described in the literature, they are PCR negative, and even some of them do not have a contact history, with a COVID patient. So but once you test antibodies, some of them will be positive. Of course, there's a small minority that both are negative, but it just fits the picture so nicely, right? And whether these are fits into the picture, or are we just dealing with the usual inflammation condition that we see in the picture? Yeah.
Are there any other questions from the floor for our panelists? There is a Q&A function at the bottom of the Zoom screen in case you're looking for a way to ask the questions. How often do you have peak ARDS in COVID-19 children? Is it according to the Gattinoni's concept about ARDS? Anybody want to take that question?
As I presented in the epidemiology slides, COVID pneumonia leading on to ARDS is something which is not often described in children. And our own experience, as I said in early pandemic, we just had 3 children who required ventilation for COVID pneumonia and ARDS, of which 1 child died. So I think ARDS as a presentation, like what is seen and described very often in adults, in our experience is something which is less often seen in children. I'm not sure if the same as in Singapore and UK, but in India, that's what we have seen, and that mirrors some of the data which has been published from China, from US, as far as children are concerned. So I would be happy to know what is the Singapore and the UK experience on this.
Just from the UK perspective, I think we've seen probably, again, a very handful number of pediatric patients needing ARDS-like management. I have managed about 2 patients on oscillators with severe ARDS. Almost all these patients have multiple complex comorbidities in the background. I don't think we've seen any newly affected children with no previous conditions with severe ARDS. So the background comorbidities seem to have a significant influence on the ARDS. And I suppose clinically they are really, well, at least haven't seemed very different from, say, for example, bad influenza, pneumonia, and ARDS. So I don't think we have enough experience to classify them according to the Gattinoni phenotypes, which I'm not sure even that is now accepted that much in the adult world either, the Gattinoni phenotypes. So I think we probably don't have the least experience in pediatrics for some ARDS from COVID. I don't know what your experience is, Jan Hau.
I think Dr. Gattinoni is actually speaking next in the plenary for APICS, so we should go and listen to what he says.
Yes, 3 more questions, so let's take these questions before we close the session. So the first is, when do you use high flow versus non-invasive versus intubation with endotracheal tube for COVID-19 patients? Are there any strict criteria for using them?
I think maybe I'll take that question. I think based on the guidelines, or I think my personal bias is to continue with what you're doing with your other patients, right? And I think so far we know that actually current PQ can support on what we're doing well on a daily basis should be what we're doing for our COVID patients. So depending on your particular site, what's your threshold or NIV or high flow, as well as for intubation, I think these should remain the same with the appropriate, infection control measures being put in place by your respective hospital. So I think, at least for myself, I think I would just stick to what we are currently doing and do not change something too drastically. And I think the current experience seems to be pointing that way. I think. Yep.
And I see the rest nodding their heads in agreement. Okay, so we'll take the next question then. When do we use steroids for peds COVID? What is the criteria for using steroids? From the guidelines that were presented earlier, I see that methylprednisolone 10 to 30 per kilo was what was recommended. Is this something, the same dose as used at your centers? And how do you choose which patients get them?
I think there are 2, so if I may pick up that, I think there are 2 phenotypes. Obviously, the acute peds COVID infection patients with respiratory failure with ARDS, you would usually, currently after recovery trial results, I think you would give them dexamethasone as you would for the adults. And those would be for either ventilated or oxygen dependent adults, but probably now applicable to children as well. I think it'd be very difficult for us without the evidence to say we won't give it if the adults have proved that it's very useful for adults. And then the second phenotype, which is the PIMS-TS or the MIS-C phenotype, I think the steroids are usually either as a second-line therapy after IV immunoglobulin or as an additional first-line therapy with IV immunoglobulin if there is evidence of coronary artery aneurysm or very small infants with significant sort of critical illness. Now, none of this obviously is evidence-based because we don't really have any supportive strong evidence, but that's currently what the UK practice is, but maybe different in other parts.
Does anyone else want to comment on that before we take the last question? Is it the same?
Yeah. I think I agree with what Ram has said. So for the COVID pneumonia ARDS, we are using dexamethasone. The dose is 1 milligram per kg and maximum is 6 milligrams, which we give for a total duration of 10 days. So this is what we are using for COVID pneumonia, a hypoxemic child, some child who's diagnosed as SARI, that is severe acute respiratory illness, with hypoxemia, fits into definition of COVID pneumonia and maybe an ARDS. So we use dexamethasone in all these children. And we use methylprednisolone for the MIS-C kids. So this is probably the difference in the steroids. And again, as has been amply clarified, most of these are extrapolations from adult trials. Obviously, we don't have robust evidence as far as children are concerned.
Thank you, Dr. Jayashree and Dr. Ram, for clarifying that. We have one last question, but I suspect that the answer is probably going to be quite similar. Are there any severe complications arising from kids after they've recovered from ARDS? Has anyone followed up their ARDS?
I think we have to probably learn from our adult colleagues. Our numbers from kids ARDS from COVID hopefully will stay low, right? But we probably need to pick some direction, some data from our adult colleagues, and of course from the small cohort that we have, from worldwide, you have to wait and see whether they have any long-term effects on, from this infection.
Just one piece of good news that we know from the American cohort, from the MIS-C patients, is that the coronary artery dilatation seems to be transient and recovers. So the longitudinal assessment of a cohort from, I think, Chicago showed that there was improvement in the coronary artery dilatation and brightness. And most patients actually recovered without any permanent aneurysms. So if that one particular thing, we have some evidence and it seems good.
Okay, thank you for that. And thank you all the attendees for being such a participative and interactive group. We had 4 very fabulous talks today, and personally I learned a lot from this. And I thank the speakers for your time and for joining us. So we'll close the session. Thank you very much.
Everyone.
Thank you. Thanks a lot.